Okay, this meeting here today is all about cutting costs in healthcare and making the quality of healthcare better, all at the same time. We're conducting rather desperately to do that in Holland, and I don't think we're very far in reaching that goal yet. You are here today, and you are probably here, I reckon, because we can learn something from the British in that respect. What can we learn from you?
Well, I think we can learn from each other. We're at the beginning of the same journey. We've got to take costs out and we've got to make sure we improve quality. I think the challenges for us all is what do we do about helping the public understand the way in which we need to change services. There's a great attachment to hospitals, and I think we should try and encourage the public to start judging our quality of service by our ability to keep them out of hospitals. And if we
How do you do that?
Well, we need better primary care and we need better community services, and we need to join up the health and social care aspect so that we can keep people in their own homes for longer. We have a phrase, there's no bed like your own bed, and if you can stay in it and we can put services around, we can perhaps take some of the costs out because our hospitals tend to be quite expensive.
Yeah, you need better home care, so you need better general practitioners.
Yes.
We're facing the same problem here. We're having a minister who doesn't see the need, or doesn't seem to see the need for general practitioners to take over more care from the hospitals. Is that the same problem you're having in England?
Well, I think England does have a strength in general practice. We've had well-developed general practice for quite a number of years. In fact, 99% of the population is registered with a general practitioner. And what that means is that the generalist, the general physician, can actually absorb quite a lot of healthcare acuity, if I put it like that, and take away the need for hospital. But what we'd like to do is to capitalise on that ability to sort of maintain people in their own homes by bringing the specialists away from the hospital sector, working with the generalist to sort of put care into people's homes. So older people's care, paediatric care, I don't know why they're still fundamentally a hospital-based service. We should have those in our community.
Right, so you want the general practitioner and the specialist to work together outside of the hospital in home care units, or whatever you'd like to call them.
Yes, I think so. I think that's the way to get the best out of having a generalist try and deal with a large number of problems without incurring the costs of the specialist. But when you do need a specialist, you bring them earlier. So actually, rather than sort of bounce backwards and forwards for a large number of episodes with your general practitioner, the general practitioner and the specialist work together, and you diagnose the problem earlier. And in the whole lifetime of costs of a patient, you keep a much smaller sort of quantum of costs because you've got the two working together.
How do you get a specialist so far that he actually comes out of the hospital?
Well, I think we have to talk to them about the need to move them away from their attachment to beds and to admitting people. The technology now allows people to have diagnosis, sometimes digital diagnosis. You can monitor your own conditions, and I think we try to help them understand that the healthcare of tomorrow doesn't really attach you to your beds in the way that it used to, and we can do so much more using that technology to help people, as I say, stay at home, and we avoid that cost.
But is it a question of money for the specialists to come out of the hospitals, or is it something else than that?
Well, we know to our cost in England that when you try and change medical practice, you often have to buy the behaviour in the way that the consultants work, and at the moment none of us, and I think you're in the same position, have that money, so we're going to have to try a different technique to try and get them to think about where is the best for their patient, and perhaps this time we won't have the money to throw at them. We're just going to have to hope that the moral high ground is to get the consultants to work with the GPs and then do the best for patients.
That's a long way.
Well, yes, but I'm encouraged. I think that most people believe in their health services. They want to keep this equality of access that we're all striving for. They want a fair health system, and we want to be able to meet the extra demand that we know's coming down the line. So people know they've got to change. And if there's any silver lining to the cloud of the recession and the economic problems, it's again a saying, necessity is the mother of invention. This time we really can't afford not to.
where does the health insurance company or the government come in this story?
Well, I think you have a system where your payers, the health insurers, really need to drive this change. They need to be taking the advantage of having competition amongst providers for the right to provide care. They need to use that to drive up quality, and they need to use that to work with those providers that want to change their models of care. And I think you've got a well-respected system of health insurance, because the Commonwealth Fund described that the Netherlands had one of the leading health systems in the world, and I think you could capitalise on that.
Yeah. Okay. And that healthcare system, should that be a healthcare system in which parties work together, or are competitors in the market?
Well, I think all markets mature in time where people recognise the need to collaborate on certain things, and where you might compete on others. And again, I think we've got to move quickly in healthcare to understand the kind of market conditions that will do the best for patients. Free markets, I think, completely free markets, they polarise the gap between the best and the worst, and in healthcare terms we can't afford to have the worst in play, if I put it like that, because that generally is a matter of life and death. So we need to help I think specific conditions in the market to emerge, and in some cases we might be saying, and again the insurers have got a role here, actually we're going to specify the fact that you should collaborate and not compete on this one. In other areas we're interested in competition and price reduction to try and get the best value. So I think the insurers again have got a big role to determine what type of healthcare market they want.
So regulated markets instead of completely free markets.
Yes, I think so. I mean, most economists across the world would say that health is not like other commodities. It's not like buying or selling shoes. You're trying to make sure that there is a basic level of care in anyone who's licensed to provide. And we know if you have diminishing money, the risk is that the quality for the patient suffer. So I think you do have to intervene in those markets, and the notion of a regulated market is probably much better than a free market for healthcare.
Is our healthcare system something the British are looking at and thinking, oh yeah, we want that? Or not at all?
No, I think we are looking. We very much look at the way that I think you've made the changes. At the moment we have a situation in the UK where we're not allowing price competition. And I think that many people are thinking, well, the Dutch system does allow price competition. Let's see if they can introduce that in a way that gets the value for the taxpayer without reducing the overall quality. And I think if you could demonstrate that, I think we would flip in the English system to do the same.
Well, we're trying. Thank you very much.
No, thank you.
Okay.